In this video, I'm going to be talking about central lines. I'm going to explain what they are, what are the types of central lines, what are the possible risks and complications of these procedures, and how to take care of the central lines after the procedure. A central line is a type of intravenous or IV catheter, and the common thing between all types of central lines is that the tip of the catheter goes in a very large vein in your chest, which is called the superior vena cava, and that's called a central vein. That's why they're called central lines. Now, there are several advantages of having the tip of the catheter in a large central vein rather into a peripheral IV. The main advantage is in the central veins, there's a lot of blood flow. So when you inject a medication there, it gets immediately diluted and immediately goes to your circulation, as opposed to injecting a medication into a peripheral vein that may stay there for a while before it gets to your circulation and can damage that vein or may not work as well. Also, when you have a central line, you're sure you are administering that medication inside the vein because you are in a big vein. Whether if you have a small IV catheter in a peripheral vein, sometimes they may not be quite into the vein or they may be partially into the vein. So there's a risk that whatever you inject instead of going into the vein could stay in the subcutaneous tissues under the skin, and depending on the medications, that can damage your tissues there. And central line is very important in several conditions. For example, when you're doing chemotherapy, you don't want to have the medication in a small vein that could destroy the vein or not work very well. Also, patients that are really sick may need a central line because you need that medication to go into the circulation as soon as possible. Some types of antibiotics may also be toxic to the small veins and may require a central line. Also, patients that require dialysis on another procedure called plasmapheresis, which is when you remove antibodies or toxins from your blood, also need a line in a very large vein because you need a lot of blood flow running through these lines to be able to clear the blood from toxins. Another situation that patients may need a central line is patients that need TPN or total parenteral nutrition when they need nutrition through the IV. Well, those nutritions require a large concentration of glucose to be able to feed the patients. And if you put those in a peripheral vein, they will destroy the vein, so they need to be injected in a very large vein. So what are the types of central lines that can be used? So there are several types of central lines, and those are used for different conditions and different situations. The most simple type of central line is just called a non-tunneled central line. Non-tunneled central lines are essentially simple, small tubes that are inserted in a central vein directly either into the internal jugular vein, in the subclavian vein, or the femoral vein. Those are only used for hospitalized patients, and usually patients that are in the ICU and they are very sick, and the reason is because those are very simple to put in. They can be put in very quick and they can be used right away without problems. The problem with those lines is they can only stay for a few days, maybe a week or so, because they have a high risk for getting infected at some point. So certainly the patient cannot go home with those lines. They're very close to a central vein and they only can last a few days. We use non-tunnel central lines for patients who also need emergency dialysis, for example, patients that are in acute renal failure and need to be dialyzed right away. So those are the simpler lines to put in, and they can put in 5 minutes at the bedside, usually either again through the internal jugular vein or through the femoral vein. They are a little bigger than the standard central lines that are used for IV medications, for example, because you need a lot of flow coming out of the body to run through the machines to get the blood cleared. The standard tunnel dialysis line that we use for dialysis is called a trialysis catheter, and that can be used for dialysis, can be used for plasmapheresis as well. And it has an extra port, an extra line that can be used for IV medication. So they're very handy in a very sick patient. Now, there's also another type of non-tunneled central line that is inserted through a peripheral vein in the arm. That's called a PICC line. They're probably the most common lines that patients may have in the hospital. If you were hospitalized for a certain period of time, you likely require to have a PICC line. And those are very useful for medications. They can be used for TPN, they can be used for antibiotics. The other good thing of PICC lines is that they can be placed at the bedside. They have very little risk of placing them. And also they can be used at home, so patients can go home with a PICC line and use them for antibiotics if they need for several weeks, or even for TPN. And some patients I've seen can keep a PICC line for up to a year or two if they're undergoing total parenteral nutrition, if unfortunately they require nutrition by IV because they cannot eat. So those are the non-tunneled central lines and the PICC lines, which are the simplest types of central lines. Now then we move on to what's called a tunneled central line. So tunneled central lines, they're usually inserted in the chest. They can be inserted in the groin, although we certainly prefer on the chest. And they are essentially, they go into an IV like a regular central line, but they are tunneled under the skin before they enter the vein, so there is more space between the vein and where the line exits the skin. They also have a little cuff that will not only get scarred in the tissue and will prevent infection from going in the body, but also will prevent the catheter from being accidentally pulled. Now, the most common use for a tunnel central line is for patients that require dialysis. And they're usually inserted on the chest, and they can be used right away as opposed to a dialysis access that's placed in the arm. So they're the most common form of access for initiating dialysis. The dialysis lines, they tend to be thicker. They are 4 to 5 millimeters wide because, again, you need a lot of blood flow to be able to filtrate the blood in an efficient fashion. But we also have some small bore tunnel central lines. They are called tunnel PICC lines. They also inserted the same way, and they have a little cuff that prevents infection from going in and prevents them from being accidentally removed. Those are used for patients who need to use a long-term central line every day, especially patients that cannot have a PICC line. Because in general, if you need a long-term IV that you use daily for antibiotics or for TPN, we tend to prefer a PICC line. But some patients may not be able to have a PICC line either because they have blood clots in the arms, or because they have narrowing in the veins, or sometimes because their arms cannot be used because they have lymphedema or some other condition. Things like that happen. So the small bore tunneled central lines, or tunnel PICC lines like we call them, they look and feel the same way as a PICC line. They're just located in the chest, and they have that little cuff that I talked about. Now, there are two other types of tunnel central lines that are a little bit special and you may hear about. One is called a Hickman catheter. A Hickman catheter, most of the time, is only used for patients that are getting bone marrow transplants these days. And it looks like a tunneled central line, except that it's a little bit bigger. Instead of being 1 to 2 millimeters, it measures about 3 to 4 millimeters and is used for patients that require a bone marrow transplant. That's the only use that I've used in the past few years. And the other special type of tunneled central line that you may hear about is called a Groschon catheter. Now, they're very similar to a tunnel PICC line, but they have this special valve that reduces the need for daily flushing and theoretically lowers the risk of having a blood clot in the catheter. But I'm not sure that in practical terms they are better than having just a tunnel PICC line or a regular PICC line. Now, the more invasive type and more permanent type of central line, it's called a Mediport or a Portocat. And I made a full video about that you can check. And this is a device that is completely implanted under the skin. It's usually implanted in the chest, but can also be placed in the arm. And then it's connected to a little tube. And this little tube tip is in the SVC, in a central vein again. So when you need to use a Mediport, what we do is you get a needle and you puncture the skin into that little container, that little reservoir, and then you can draw blood or infuse medication or chemotherapy, for example. The main advantage of the Mediport is that when you're not using the Mediport, it's like you don't have any tubes hanging out, and you can go ahead and swim and play golf, do your normal activities, and you don't have anything hanging out. So it's very useful for patients that need an IV frequently, let's say once a week, but they don't need every day. If it's something that you need an IV every day, you would always need this needle in there, and so it kind of defeats the purpose. In those cases, we tend to prefer a tunnel line or a PICC line. But there are some patients that need an IV every day, for example, for TPN, and they prefer a port, although I think it's less ideal for that. Mediports are typically used for chemotherapy, cancer patients. And like I mentioned before, chemotherapy can be very toxic to the peripheral veins and can destroy the veins. So in general, it's preferred to do chemotherapy to a central line, especially a port, because these patients don't need to use the line every day. They are usually using once a week or every 2 or 3 weeks even. So whenever they have to use, it's easy to just put a needle, use it, then you take out the needle and you can go to the hot tub or swimming pool and you can do your normal activities. So how are these procedures done? So most of these lines these days are placed by interventional radiologists, who are physicians that are highly trained and specialized in using imaging guidance like ultrasound and x-rays to place these devices. Non-tunneled central lines are usually done at the bedside for very sick patients. PICC lines can also be placed at the bedside, and they're usually done by actually specialized nurses that are trained to do them. But in more difficult cases, if you have a weird anatomy or you have a narrowing on your vein, they may be placed by an interventional radiologist like me as well, because we have a capability to use x-ray guidance and venograms, which is when we inject contrast in the veins, to actually find the correct route to get to a central line. Sometimes we even open a vein that is blocked to be able to put one of these lines. Tunneled catheters and lines are usually done at the catheterization laboratory because we use maximum sterile technique, and we also make sure that they are placed in perfect position. You also, for those, will be receiving what's called moderate sedation or mild sedation, and that's when we administer medication in your IV to make you comfortable. For non-tunneled and tunneled lines, after we place, we may use a dissolvable stitch at the entrance site to make sure the line doesn't get accidentally removed, and that stitch will sometimes dissolve, because after a while you don't need the stitch anymore, because that cuff that has in the line usually gets scar tissue around and prevents it from coming out. These procedures are pretty quick. They usually take 5 to 10 minutes, and you'll be comfortable throughout the procedure. So what to expect after the procedure? So most of the time you may be a little sore where the procedure is done, but severe pain is very rare, and you also should not have severe pain when taking a deep breath or doing anything like that. It's also normal to have some bruising at the site, and the bruising sometimes can get worse by next day, but it shouldn't be associated with a lot of pain. The pain should be getting better even if the bruising is getting worse. And then we'll stabilize and go away in the next couple of weeks. So these are the normal things, but what are the possible complications? Like, any procedure has complications. One complication would be a bleeding complication. And like I said, bruising is normal, and we don't worry too much about that, especially if you're not having any pain. But if you're having more and more pain and the swelling in the site is getting worse and worse, that's something that you need to let us know right away, or even go to an emergency room to get it checked, because this could be an internal bleeding or hematoma. With any lines, there is definitely a risk of an infection. Obviously, the risk is higher with the central lines, like I mentioned before, but any of these lines can get infected. The risk is lower with the tunneled central lines because those have a cuff and they are tunneled under the skin, which protect for entrance of germs, but infections can happen. Now, infections with tunneled catheter, they're rarely related with placement of the catheter. So the infections are more related to using the catheter, manipulating it, doing injections, and they can happen at any time. Even patients that have the catheter for a year, for example, for dialysis, they can have an infection at some point. The way you would know if you have an infection is usually you develop either a fever or the site of the catheter would get progressively red and painful. If that happens, you need to let us know, because you may need antibiotics, may need to be admitted, because these infections can be serious and can lead to sepsis. Another complication of any of these procedures, especially if performed in the chest, they're not so much if you're putting a line in the groin or in the arm, but is a risk of something called a pneumothorax. A pneumothorax is a partial lung collapse, and that would happen if you accidentally hit the lung with the needle when placing these lines, or if the wire went in and damaged the lung. And they're really, really rare these days, because we do these procedures all with imaging guidance, and we can see these needles going in the vein and we can see where the lung is. So those are really, really rare these days, but it is possible in a very difficult case with a complicated anatomy. So if you develop shortness of breath or chest pain that is new, you need to get it looked at, and the way to diagnose would be to do a chest x-ray. Now, a more common problem that we see, it's not super common, but we see especially with PICC lines, is to develop a blood clot where the line is going into the vein. And that can happen with any type of central line. It can happen with a PICC line, can happen with a tunnel catheter, or it can even happen with a Mediport. And if that happens, the most common symptom would be arm swelling. The other symptom that we see is some patients can develop severe pain in the neck. And that's if this vein, the internal jugular vein, gets clotted, and the clot can be inflammatory and can cause pain in the neck. So if any of the symptoms happen, arm swelling or pain in the neck area, in the jugular vein area, it's something we need to look at. And the way to look at would be to do an ultrasound to make sure there's no blood clot. If you have a blood clot, those are usually treated with blood thinners. If the blood clot is severe, sometimes you go in and do a procedure called a thrombectomy, that we put a little catheter through the groin and we navigate up and aspirate or suck these clots out and clean the veins again. But even if we do that, you need to be on blood thinners afterwards. The question is, if that happens after we clear the clot and start the blood thinners, is do we keep the catheter in the same place? Do we take the catheter out? Do we put it in another place? And that will be a decision between you and your doctor, and we'll be happy to discuss and see, but it's done on a case-by-case basis. Now, one problem that can happen in patients that require central lines for a long time, and this is most commonly seen in patients that require TPN, because sometimes they may require a central line in there forever, is that some patients can develop scarring of these veins. So the veins may clot and sometimes may scar down. So with time, you may run out of veins, and people may have a hard time putting catheters in, and that may become a problem. I'm not talking about months or even a few years, but like if you need a catheter for a long time, this can be an issue. And I've seen patients in the past that run out of veins in the arms and in the neck, and you cannot put a catheter here. And then you may try to do a groin catheter. Those are more tricky because they tend to get infected more often. And I've seen some patients requiring a catheter going in a vein in the liver, for example, for TPN, or even having a catheter placed directly into the inferior vena cava to get the treatment that they need. But this is very rare these days because we have a new device called the Surfacer device, which I made a full video about it, and you can take a look. It's very interesting. But it's a catheter that we are able to go from inside the vein and then tunnel these catheters through the skin that way. It's a very interesting thing. You should watch the video if you're interested in these things. But if you're a patient that needs a long-term central line, you should be very careful when you choose where to put in these lines, and you should have a really good interventional radiologist to take care of you. Now, lastly, the other complication that we see with any of these catheters is called a fibrin sheath. And a fibrin sheath happens when these catheters are there for a long time, and that's when you build some scar tissue around the tip of the catheter, and that can prevent either aspirating the blood from the catheters or even clogging the catheters completely. But the most common thing is that you can infuse through the catheters, but you can't aspirate because they have like almost the body creates a little valve at the tip. If that happens, it's something that needs to be looked at, usually by an interventional radiologist. There are 3 ways that we can deal with them. One way is we can inject a medication called TPA and infuse through the catheter. That has to be done in the hospital because we infuse usually over an hour or so to try to clear the blockage. The second way, sometimes if you have a catheter in the chest, for example, we can go from the groin and use a little snare to kind of strip and clear the tip of the catheter to make it work better. And the third option, that's probably what we use more often because it's more long-lasting, is just to actually take the catheter out and replace with a brand new catheter that then will work fine because it's not going to be going through that fibrin sheath, through that scar tissue. Now, what do you have to do and how to take care of your central line? I'm going to start with the port because that's the easiest one, because the port's completely under the skin. So when the port is healed after a couple of weeks, you can do everything that you normally do. You can swim, you can shower, you can play golf, play tennis, do everything essentially, because it's completely under the skin and there's nothing sticking out. Now, when you have something sticking out like a PICC line or a tunneled central line, it gets more tricky because you need to maintain it clean. And also you need to be very careful while using these devices that you use appropriate sterile techniques so they don't get infected. Now, PICC lines, they go in the arm. They are a catheter that is exiting the arm. And they have a lot of devices on the market, so you can wrap the catheter and take a shower with them. And then after the shower, you can unwrap it, and so they don't get wet and the dressing doesn't get wet. Usually these dressings need to be changed. They can be changed by a nurse, or people who have long-term, they learn how to change the dressing. Obviously, every time you change the dressing, you have to make sure you don't pull the line, dislodge it, or do anything like that. But people who have for a long time get used to it, and people who have for a short time, usually they have a nurse that come in and help them then changing the bandage. They use special dressings that are made for PICC lines, and they're very good to secure the line and keep it clean. Now, when you have a PICC line, again, the most important thing is to use really good sterile techniques so they don't get infected. So tunneled PICC lines, they are treated essentially the same as a PICC line. Now, tunnel lines, they have a cuff that protects from bacteria or even water from going in around the catheter. They really seal the area. So I think the key with those is to keep the site very clean. And also patients who have them for dialysis, for example, they have for a long time. And I have discussed this with a lot of different physicians, and most physicians would agree that the most important thing is to keep the site very clean. And we think that even cleaning the site with soap and water, like in a daily basis, or every once in a while, it's a good thing to keep the site clean as long as you use a clean dressing afterwards. There are sterile pads that you can apply over the dressing, and I think the important thing is to change the dressing frequently. I don't want that dressing to stay there for like several weeks, so it accumulates moisture and discharge in the site, and that can be more prone to infection. It's important to look at the site every day or every few days to make sure that it's not getting red and there is no purulent discharge coming off the site, because if you have any of those, you have to let us know, since you want to make sure to treat it quickly before things get worse and you may develop sepsis or something like that. As far as the central lines, they obviously need to be flushed regularly, like your doctor or your nurse will advise you how often it needs to be done. But of course, if you're using the line every day, you want to make sure that after you use, you flush it really well so it doesn't have any blood clots inside it. Again, for ports, this is very low maintenance unless the port's being accessed. And before removing the needle, usually the nurses will flush it really well so it's clean inside. And they may tell you that in general, if you have a port, it's probably a good idea to flush it every couple of months to make sure it's working. But my opinion is that if you are not using a port for a couple of months, you probably should have it removed, because they can always be installed again if needed. And there's no reason, if you're not using it, there's no reason to keep it. So in summary, I hope I gave you a very good idea what central lines are and what are the types of central lines, because they're very important tools to treat the patients. In our practice, it's a very common thing to manage these things. If you have any other questions about central lines, or you're not sure what option is good for you, you can also contact our office and we'll be happy to have a discussion with you.